Good morning, and thank you to the moderators for invitation to speak today. My only disclosure is that I lack Dr. Pauly's flair for the dramatic, so I may not live up to the last presentation. ERCP, or endoscopic retrograde cholangiopancreatography, is a very common procedure. Over 500,000 are performed annually in the United States, and they come with a complication rate of 4 to 10%. And this can come mortality rate of usually less than 1%. But as MRCP, MRI, and EUS have become more advanced, they've taken over as the diagnostic modalities, and ERCP is used exclusively as a therapeutic procedure. And in fact, the NIH has recommended against the use of ERCP for diagnostic purposes. With that, you have an increased risk and rate of complication, and especially as we become more advanced and more forceful with our therapeutics. And so the goal then for the endoscopist is to minimize complications, and the way we can do that is with good patient selection and with excellent techniques. And then also using the operating room when necessary, although you'll note in my talk that in cases of ERCP complications, it's actually very rare that that is required. Usually good technique, good patient selection, and thoughtful management with early recognition of problems can avoid necessitating a trip to the operating room. So post-ERCP pancreatitis, or PEP, is the most common and also the most dreaded complication of ERCP. It can have devastating effects for the patient and also has a huge cost for care, reaching $150 to $200 million a year to manage this problem. It is very common and can reach 15% incidence rates, and in patients with multiple risk factors, it actually can reach 40%. So that would be this woman on the tank top with a sphincterotomy dysfunction. She's young, she's female, and her risk factors increase additively with each one. Other risk factors are history of PEP or a history of recurrent acute pancreatitis. You are protected if you have chronic pancreatitis. Maybe that's the one benefit of chronic pancreatitis. Procedural risk factors are going to include difficult or long cannulations. There have been studies that note 2-minute time for cannulation increases the risk. Other studies show maybe more like 5 to 10 minutes. Manipulation of the papilla, multiple injections, sphincterotomy, and balloon dilations all increase your risk of pancreatitis as well. So what can we do to prevent this? Because a lot of my talk on complications is going to be how do we use our skills and our knowledge to prevent this so that we can avoid having to deal with the bad complications. And there are different techniques that have been studied. Probably the most accepted and widely accepted is the pancreatic duct stent. This has been shown very clearly to reduce the risk of PEP. You do have to be careful because pancreatitis is most likely coming from edema of the papilla, from trauma of the pancreatic duct, and so you want to limit the trauma that you're causing with the stent as well. So a soft stent, about 5 French, 5 centimeters is recommended. You want to put this in during the procedure and keep it for a minimum of 24 hours. They have looked at keeping the stent in just for the procedure to try and prevent this, but that actually has been shown to increase the risk of pancreatitis. So the recommendation is about 10 to 14 days. Keep those stents in. You can take an x-ray of the abdomen, evaluate if it's still there. If it is, go back in endoscopically and retrieve it. If it's passed on its own, then you're done with that. Other techniques that are very useful is a guide wire cannulation. So rather than using your sphincterotome or other instrument, you're going to just first cannulate the ducts with a guide wire. This reduces your manipulation of the papilla. It increases your primary cannulation rate and decreases your risk of pancreatitis quite significantly. If you have trouble cannulating the biliary system, and that's what you're aiming for, a double guide wire technique can also be very helpful. This one, your first guide wire, as you can see on the right there, goes into the pancreatic duct. You leave it there, kind of let it sit. It helps change the anatomy a little by pulling it down and then also making the easiest route for the next wire into the biliary system. This also can reduce the number of repetitions of cannulation required and the trauma, and can reduce the risk of pancreatitis. Thoughtful use of sphincterotomy, and then also of balloon dilation, as balloon dilation of the sphincter has been shown to increase risk of pancreatitis as well. Management is going to follow basically your acute pancreatitis pathway. We're going to start with medical management, IV fluids, bowel rest, and analgesia. You're going to have a goal-directed resuscitation, and then continue to manage the patient. Pancreatitis generally is defined as an increase in pain or new abdominal pain in the setting of increased amylase or lipase that's 3 times more than normal that requires a hospitalization. Severity of PEP is measured usually on the length of stay and then on the progression of the disease clinically. If it progresses to a pseudocyst or a necrosis, then we're going to start looking into other forms of management. Fluid collections can be drained percutaneously, and then as we start to see infected necrosis, which should be diagnosed with an FNA and onto systemic inflammatory response or sepsis, then we're going to start thinking about a necrosectomy. This can be achieved endoscopically, through a minimally invasive retroperitoneal approach, or through an open necrosectomy. And the goal is to remove all of the necrotic tissue and leave behind as much normal pancreatic tissue as possible. This has a very high morbidity and mortality rate. Again, the theme of the talk is going to be try not to get them here. Next complication to discuss is bleeding after ERCP. This has a rate about 2%. Significantly, or clinically significant bleeding is going to be about 0.5%. It's defined as a GI bleed with a drop of hemoglobin is a clinically significant bleed. Most bleeding after ERCP is related to the sphincterotomy and will be found at the apex of the sphincterotomy, but can also be due to splenic trauma, hepatic trauma, vascular trauma, or hemophilia from duct trauma. And these will be, I'm not going to touch very much on these, they're very rare. I think there's 11 or 12 cases of splenic trauma that have been reported, but you're going to manage those as trauma, as solid organ traumas. Bleeding, the risk factors for bleeding are going to be patient-related, mostly with coagulopathy, with use of anticoagulants, and then active cholangitis increases your risk as well. As you heard before, it is safe to proceed with ERCP on a low-dose aspirin. The studies around clopidogrel and other antiplatelets are unclear, although most recommendations are to stop them 5 to 7 days before the procedure. And this is where patient selection and patient preparation is going to be very important in trying to prevent this. There are also technical aspects, such as the type of energy that's used, and it's found a mixed or blended energy is going to reduce your risk of bleeding as well, and then also the volume of cases by the endoscopist. When we do have a bleed, they can be either immediate or delayed. If they're immediate, you're most likely going to see them during the procedure, and at that time you can proceed to treat as necessary. Otherwise, you're going to correct any coagulopathy, treat with blood transfusions as necessary, and then treat any underlying diseases. Renal failure is a risk for bleeding. Dialysis around the procedure can help prevent this as well. Do it first endoscopic management as possible. Your first line is going to be injection of a diluted epinephrine solution. It usually takes 1/2 to 4 milliliters. You inject into the mucosa around the bleeding area. You can try to place a through the scope clip. Can be quite difficult with a side viewing scope, and so you may need to actually use a front viewing scope with a cap to help good control of that, but place a clip in the apex. Of course, while you're doing all of these, you have to be aware of where your pancreatic ampulla and the biliary ampulla are so that you don't occlude these or cause further trauma as well. For refractory bleeding, you can see here the self-expanding metal stent. can be very useful. It causes just compression of the bleeding. That they are very expensive, and you have to go back and take them out. So again, it's kind of getting to your last ideas to use those. And then for patients that have bleeding that are refractory even to the self-expanding metal stents, the angiography is going to be your next step. Angiography and surgery have actually been studied side to side and found to be equivalent in their outcomes and success rates. So you really almost never need to take these patients to the operating room. It may take 2 or 3 trips to the angio suite, but you can get 100% success rates with these as well. And these can also be used to treat pseudoaneurysms and vascular injury. Perforation due to ERCP is quite rare. It's probably less than 1%, but it obviously can have very devastating results with mortality reaching 8 to 23% if it's not diagnosed and managed early. Perforations are generally in 4 areas and kind of defined that way. The first being a side wall or the lateral wall of the duodenum, most commonly between the first and second portion of the duodenum. There are sphincterotomy perforations. There are perforations of the ducts themselves, and then you can get diminutive retroperitoneal perforations from using wires and other instruments. Risk factors for these, the patient risk factors are very similar to pancreatitis, although their older age is the difference, but female, sex, sphincter of Oddi dysfunction, all of those increase your risk of perforation, and then of course abnormal anatomy. So whether someone has situs inversus or if you've given them a Bill Roth 2 reconstruction, that can increase your risk of perforation as well. And much of this comes down to a technical problem or aspect that you should be aware of. The diagnosis is going to be intra-procedural. If you see it, you're going to try and treat it right there. Otherwise, you have to have a high suspicion for it after you've done a therapeutic ERCP, and you're going to look for signs and symptoms, abdominal pain, tachycardia, fever. The difficulty here is that pancreatitis or PEP and perforation can have very similar presentations, and so you have to figure out how to differentiate them. Imaging is going to be your friend at this point. If you are suspicious during your procedure, like on the right you can see some air that's probably not supposed to be there along the edge of the liver. Inject some contrast, look for your leak at that point, and that can help you identify it and then manage it right there. CT scan can be very helpful. Other signs like subcutaneous emphysema, peritonitis, and then when you're getting into SIRS and sepsis are signs that these need to be identified and treated quickly. Your management, again, is going to start with medical management. As soon as you're suspicious, IV fluid with gold-directed resuscitation, antibiotics, bowel rest, and then make your diagnosis, whether it's with imaging or endoscopy. And then treatment goals are sepsis, source control, and repair of the injury. If you can manage this endoscopically, you're either already there or your patient's hemodynamically stable enough to tolerate it, and you're comfortable, by all means try. Clips are very successful, either through the scope or over the scope clips. Stents can be used in this situation as well as the endoscopic suturing device. However, in patients that have signs of uncontrolled leak or hard surgical signs, the best place for them to be is the operating room, and this is where I'm going to diverge from the previous portion of the talk, because this is where you can save lives and prevent long-term complications. Treatment, again, is source control and repair. It can be a primary repair with drain placement. It can be a serosal patch or pyloroplasty, pyloric diversion, and a repair at the surgeon's discretion. But again, the goal here is early recognition and appropriate management. So in conclusion, patient selection, good technical skills, and thoughtful post-ERCP management can prevent and reduce complications from ERCP. Thank you.